spine. And then last night I looked at the program and it says updates in neurosurgery. So you'll have to bear with me, I'm not a neurosurgeon. In the world with spine, the neurosurgeons and the orthos overlap a lot, except they do brains and spinal cord tumors. It's any consolation, we had a case a long time ago where a young boy was involved in an accident and lost like half his brain, and the doctor trying to console the mother said at least he could be an ortho when he grows up. This is it's a broad topic of what to talk about. You know, wondering like what's in your guys' mind, what would you want to know about? Being sort of an environmentalist, I thought, why don't I do some recycling? So I thought about it, and several years ago I wound up going to the Philippines, and because I was able to arrange giving a talk at a medical school, I was able to deduct some of the expenses. The talk was on preventing spine surgery in spine surgery complications. And if it's any consolation, just like in America, when I gave the talk to the Philippines, half the residents were on their phones. So anyway, this wasn't the group I spoke to, but in case you couldn't tell which one is me, I've got it marked there. They even let me do spine surgery on their food. Anyway, the purpose of the talk there and here is to share ideas. You know, we can have questions afterwards or whatever, but I'm trying to give sort of a broad-based view, and I was trying to think of the theme, what do scrub techs want to know? And it would seem like a simple question, but you know, there's always the issue of perspective. You know, some people see things one way, you know, some see it another way. So when I'm in there, and I'm a surgeon, I'm focusing on trying not to cut the wrong thing or get in trouble. And on your guys' end, I don't know what's going through your brain. You know, there's someone who I work with, and sometimes it takes so long, I wonder if she's trying to kill herself to get out of the case. The thing about spine surgery is that the difference between a good case and a bad case really comes down to the thickness of the balloon. A balloon, not the balloon. There is a structure, you probably heard epidurals for people having babies. The dura is like a balloon that keeps the spinal fluid around the spinal cord and the spinal nerves. And staying out of that is really important. So by the time you get in there, maybe you talk to your team a little bit, but a lot of times you really feel like you're getting to work when the patient's asleep and face down. And before getting into those details, I thought I'd make a little detour and talk about a couple things that happen before you see it. First of all, who are the people that are going to wind up on your operating table? Let's meet the candidates. So I'm sure that you have all had or know someone who has back pain or neck pain or some other problem that they think rocks their world. And if you put all of them into one bag or one big pie, when you eliminate the people who either want surgery and aren't candidates, or who aren't candidates and don't even want it, or vice versa, whatever, they have stuff and they don't want anything done, you wind up with only a small piece of the pie that might actually wind up on your OR table. And there's a number of factors that influence this, all outside of your point of view. One is the whole idea of risk. You know, when I talk to people, I say you're going to have one of three outcomes with what we do. You're going to be better, same, or worse. And they literally recoil at the word worse. Like, well, what do you mean? I said, well, you know, people get in accidents all the time. I mean, they don't plan to have that happen. The chance might be small, but it's not zero. The other thing I tell them is that the only guarantee is that there's no guarantee. And if they're put off by that, they need to think longer, because it's absolutely true. I mean, I tell them if I do 100 cases and I give myself an A on execution, like I was happy with it, I will not have 100 happy people. There may be some who think, well, the scar hurts a little bit, or it just didn't help as much as I thought, or it's stiffer, or whatever. So the whole thing is managing expectations. I want these two lines to be overlapping so that they can have reasonable expectations. Because, you know, once I put a knife on them, they have like a right to come back and knock on my door. Hey, you did this, and I was fine before your thing. So I want them personally to be part of the decision. So there's one other thing that I just did want to go over with. It's not particularly scrub related, but by the time they get on your OR table, you don't know what they've had to go through. And it used to be that we would get things improved, but we're getting to the point of having to jump over higher and higher hurdles just to get anything done. So 10 years ago or so, we'd have reasonable indications, we'd have the appropriate labs, we'd have the right pathology, and we'd have a plan that would work. Now I think they sit around at insurance companies in their cubicles, just high-fiving each other, just looking for reasons to say no, because it's just ridiculous, the things that I have to fight. But I feel like I'm a soldier in the trenches fighting for these patients, and no one does anything, and the insurance commission doesn't help, there's no help, so it really just comes down to like, if you are shameless, that is a superpower, and they are shameless. The health insurance denials are on the rise, but you can all be comforted because at least you know that insurance is having record profits. Anyway, let me get back to the focus of what I think is really the important thing in surgery is anatomy, because you have to know what you're cutting, what levels, what you're looking at, what you're trying to do. So these are some pictures borrowed from my own website. Feel free to steal them because I stole them. But here's the spine. The spine has a stack of bones, and it's got a lot of functions. It protects our nerves, which are very sensitive. It gives us posture, allows mobility, but it also kind of can wear out, right? So the disc, everyone's heard of the disc. The disc is like a mini waterbed or cushion or pillow. One metaphor that I like to use is like a jelly donut. There's a center part and a rim. If you step on a jelly donut, it could touch either all the nerves if it goes directly backward, or it could touch one nerve at each level. The back part of the spine, you can feel down your back, there's that bump down the middle called the spinous process. On right and left, there's muscles. Under the muscles is the joint called facet joint. They have a black star in this picture. I don't know if you can tell from this picture, but like maybe on this one you could imagine if you bend forward to touch your toes, those joints have to slide apart. There's a squishy disc in the front, and those facet joints have to slide over each other. There's cartilage on the surfaces. You've seen cartilage on chicken bones, and the chickens don't get arthritis by the time they're on your plate. But when it gets arthritic, then they're rough, and the body tries to fix it. The best way to look at the facets is on a cross-sectional view called an axial view. And if you see in the center the spinal canal where that white area is, this imaging sequence shows that water is white, and I think you can see where the black arrows are pointing. There's a little bit of white between the two sides of the facet joint, and that is what it looks like when it's normal. When you get an x-ray, you can see the disc, but the facet joints, which are a little to the right and left, are about the same density of whiteness all through the spine, but when they get arthritic, it's like the body's trying to heal the arthritis, and it makes more bone. So it looks like more of a cloud or a cotton ball there. And that also changes the anatomy when you go in there. So it's not like a textbook, it's like these big gnarled knuckles back here. The foramen is a word you might hear. That's the hole through which each nerve root exits. So it's like if I had 18 arms, the hole that my arm came out, I got a shirt sleeve, and there's air between my fabric and the arm. So if the patient develops some narrowing and there's not enough room for my arm in the shirt, that could cause problems in the arm. In this case, in this analogy, the arm is the metaphor for the nerve root. When we look at the neck, there's a big difference because there's this small detail called the spinal cord. So the spinal cord is actually an extension of the central nervous system. It's really an extension of the brain, and it acts different than nerve roots. And hopefully this picture makes sense in terms of like what's called a sagittal view, which is you cut someone in half right and left, so you can see the nose and the mouth and the tongue. But this is really a normal neck MRI. So, where it says intervertebral disc, that's the jelly and the donut it's pointing to. Where it says vertebral body, that's the bone. The spinal cord is the gray thing, and the white is the spinal fluid. Now, if you were to cut the head off or cut the neck like a salami, it would be a different view. So on the next picture, you see the trachea breathing tubes at the top of the picture. behind that's the esophagus, and then you got the vertebral body, and the spinal cord. And this is the most useful view to look at the foramen, which is the exiting nerve root as the nerves come out at each level. So big picture, what are we treating? There's two big categories, and I guess as you'll see in this talk, there's also two categories of people, those who put everything in two categories and those who don't. But anyway, there's a big category like wear and tear and arthritis, where the discs become flat tires and the joints get arthritic, and then nerve compression. And a lot of people have both. So in terms of like what I see, most of it is adult degenerative. That's what's really common. Less common, at least in my experience, is tumors, deformity, scoliosis, stuff like that, and fractures, but they have all the same principles that we're talking about here. So I'm going to go over some examples of conditions that are potentially surgical. We were talking about the cervical spine. So if you get bulging of the disc or infolding of the soft tissue in the back, you can have pressure on the spinal cord. I don't know if any of you know someone who's ever had a brain tumor, but they may not show up with pain. They may get seizures or vision changes or personality changes. The central nervous system, which is brain and spinal cord, is not a painful structure. So the person like here comes in and they are falling all over themselves, and they have balance trouble, and they have abnormal reflexes because you lose the body position sense. Like I can close my eyes and touch my nose, I feel where my hand is. Well, if you didn't know that, if you couldn't feel it, like if I close my eyes and put a stick in my hand, I don't feel the stick, so I couldn't touch my nose, and they lose their position sense with this thing. And this is one of the cases where I'll go on the record and say, dude, you need surgery, because everything else is the same thing we talked about, no guarantee, and they need to be part of it. But if this person falls and has an injury, they could wind up with a spinal cord injury. When you do see them in surgery, there's usually neuromonitoring. I don't know if they're actually looking at this or watching QVC, but there's motor and sensory potential. So motor is when they put electrodes in the brain and cause a mini seizure. They always tell the surgeon when they're doing it because it makes the person jump. You don't have a drill on the spinal cord and have them jump. So they always ask. Sensory or more continuous, where they have electrodes in the extremities and they're recording things in the brain. But if you have someone who gets like a herniated disc affecting one nerve root, and if you see on the left, there's the normal foramen, and on the right, there's an example of herniated disc material pressing on a nerve. Well, it all has to fit to get to the operating room. So I'm sure everybody has hit their elbow on a desk, and you take a funny one. So just like the ulnar nerve has a place that it goes marked out in red there, so does every nerve have a place that it goes with their anatomy of their spine. So if a person comes in and they have a herniated disc on the right and their symptoms are on the left, they're not going to be a good candidate to get better. In terms of the disc itself, when the disc becomes a flat tire, it's not supporting the weight. It's like vertically challenged in terms of taking care of the load. And if you look at the discs above, those are the jelly-filled donuts, and they have squishiness. The one that's marked with the degenerative disc, the bone is getting bruised. So think of you sitting on a couch or sitting on a concrete slab. Well, your butt's going to get sore on the concrete slab. It's going to have some damage to the tissues if there's not a good cushion there. So the foramen we talked about also can get narrow. This can be something that needs to be addressed. So the word for narrowing is in medical is stenosis. So like this diagram shows maybe some arthritis forming. And when you do the MRI, you either cut down the middle, or if you make the cut still down the middle but to one side or the other, you can see the hole where the nerve comes out. So the ones with the white arrow, you see a dark structure in the middle, that's the nerve root, and there's fat around it, just like the air around my arm between the shirt sleeve and the arm. And the middle one with the black arrow, that's an example of a crowded nerve, where that nerve, if it had pain along that dermatome, would make sense and would make them a candidate for surgery. The narrowing can also be in the central part of the spine in what's called the spinal canal, which is the area right behind the vertebral body. It can either get narrow from disc bulging or from the facetscia getting overgrown. So if you think about it, the bones are hard, and since the soft tissue in the back of the spine either gets stretched out when you bend forward or gets compressed when you lean back, one of the symptoms that people will have, and you have grandmothers who have this or whatever, that they have to lean on a shopping cart or sit down to get some relief. And that is the kind of thing it still comes down to, like, is this bad enough to have surgery? Because they're not going to die of this. And that's why they have to order off the menu. If they want to have this fixed. So everyone's heard of a herniated disc. What's a hernia? It's something going out of its normal borders due to some weakness in a wall, and it's going where it shouldn't be. So remember, the disc is like a jelly donut, so if the dough of the donut gets weak or torn, and think about it, you know those Pop and Fresh biscuits? You twist it, right? So usually the person's reaching for something or whatever, and they get a pop or not or whatever, in a few days they get some pain down their leg. Very often when you go in there, there's still a rim of dough, but it's got a bulge, and it's touching the nerve, putting pressure on it. Sometimes the jelly, or it actually is like gravity in real life, will squirt out and be in the spinal canal. It'd be like having a rock in your shoe. You know, it's not something you can ignore. It's going to get your attention. You could try all the non-surgical treatments, try medicine, try therapy, try injections, but realistically, if you've got the rock in your shoe, you're not going to take more Tylenol. You're not going to try foot therapy. You're not going to drip cortisone into the shoe. You need the rock taken out of your shoe. So this is where my slide for a drum roll, please. Now at the moment you've all been waiting for. Okay, so back to the two category of people. There's two big categories. So one is when the nerves are compressed, we are relieving the compression. It's called decompression. People always ask me, what's decompression? I just told you. Anyway, but so relieve the compression, or if it's unstable, we are fusing or stabilizing or taking care of abnormal motion in the spine. Obviously, everything here is my opinion, and as I mentioned, a big focus in doing this is to avoid injury to the dura. It's a big focus when I'm going in there to expose it. I have never gone to the waiting room and had the family say, "Doc, thank God he did so fast." So it's all relative in terms of like what type of speed someone should have doing this. You know, I did a fellowship, and one of the people prided themselves on doing this surgery so fast. I'm like, I don't care. You got to make sure you do it right. So here's some examples of decompression. So in the slide on the left, this is a CT myelogram. So the white is dye in around the nerve roots. The nerve roots are those black things. And on the right, you can see it's sort of narrow there. So this is someone who has spinal stenosis. They have to lean forward to get relief. One of the treatments would be what's called laminectomy, where you remove the bone on the backside, called the posterior of the spine. And you know, like laminate flooring or laminate on your countertop, it's a sheet. So ectomy is removal. So when you think about what is a laminectomy, it's removing that sheet of bone on the back, and it makes room for the nerves. It can be then open or minimally invasive, which means through a tubular retractor. But either way, what you're doing is removing the pressure on the back of the spine. So after you've done the decompression, there's more room for the nerve in the middle. The foramen can be narrow also, and so in this example we showed, we can go in usually with a minimally invasive technique. And here's a model that does not have arthritis, but the nerve that exits that space is where the tip of the red arrowhead is. And when the disc height gets less, the bone below it with the black arrow on it will go back and give impingement there. I can't get to it from the side, but I can get to it from the back. And if you drill away the heart towards the midline and go away from the midline, after it's done, you've made more room for the nerve roots. And it's amazing. It's just like getting the rock out of your shoe. These small surgeries can really help people. How do we do it? We use a burr, also called a drill, and there's different kinds. Different surgeons use different ones. Again, my opinion, I use a lot these two. One called fluted, which is more efficient for cutting. It's got these kind of almost vertical ridges, and it can take away more bone. It doesn't get as hot. But when you're going through thicker bone, you want to use this kind of thing because you can make more progress. But it's something that when you're getting there, it's very tempting to you're almost there, you just want to push a little harder and you don't want to pop through. And I think of this analogy, I don't know if any of you remember, there's a man, Carl Malone, and the announcer would say, he pulled away the chair. So the offensive player would be going towards the basket, he has his forearm out, and he'd pull it away, and they'd fall down. And you don't want the bone to give a sudden loss of resistance, because then if you go in and you drill the nerve, that's not good. So when we get closer, I prefer this one called a horse diamond, which is like a BB with flex on it, and you're barely touching it like you're touching a paintbrush. And a lot of times you're using some magnification, either loops or a microscope, and as you're barely painting it, you can kind of see that it starts to move a little bit. And then you just have to be very careful, because sometimes you go through and like, oh, there's the dural, it's like a big vein. It would not take very much to cut it. Dural tears do not have a zero incidence. I would like to avoid them, but you know, I mean, I don't know, I haven't really checked. I think my incidence is less, but it's not zero, but they do have it. The big problem is that spinal fluid doesn't clot, right? You can stick a knife in your thigh and pull it out and put a bandage over it, unless you have an artery pumping, it will clot eventually. Spinal fluid doesn't. The other thing is that nerve roots can come out. So you don't want to have a thing like this where spinal fluid is leaking, they get headaches and have a lot of pain. And there's an artist's rendition of like how nerve roots can herniate through a little tear, and that's terrible pain that they get. You can't just leave it like that. The other thing is, here's an artist's rendition of repairing one, but it's never like this. First of all the bone is gone on the back of this dural tube called the thecal sac. Second of all, when you really do the needle, a lot of times each needle hole leaks too. So it's one of those things that, just like seat belts in cars, you want to avoid the problem and not have to deal with it. Another surgery that you might hear about is microdiscectomy. Micro, use a microscope or using magnification. And ectomy is removal. So when there's the disc that's prominent, you're doing removal of that prominent disc. It can be open, like on the left, or tubular retractor on the right. The surgery is basically summarized in this picture here. So you make a hole in the back of the bone, you get in there, you have to pull the sac of nerves aside, and usually there's a lump. And this is great to look at this picture, but this is what you get to see. And you're looking down there, and you guys don't see anything unless there's a scope with a TV. But you know, you have to really look in your mind's eye and imagine what was in the previous slide to know that you're getting everything, and you have to be sure that you're you know, doing adequate decompression. And when you watch videos online, they always pull out a big piece of crab meat that's like the size of the tip of your finger, and I never get that, because people always wait like 3 or 4 months after that pain before they decide to have surgery, and it's all scarred. So the reality is different than what's on YouTube. So here's some examples of fusion or stabilization. If you think of what's abnormal motion, like the door should open and close. If the door falls on you or falls off its hinges, that's abnormal motion. Stabilization is needed. So when someone has a bad disc, that could be a pain generator, and you can give all the epidurals you want. At some point, they either can live with it or they can't. When they throw in the towel and say, I want to do this, then they become a candidate for fusion. Sometimes the bones will slip forward, and that's got a name for that called spondylolisthesis. Spondy is the Greek word for spine, listhesis, slipping, but that's an unstable pattern. And because it's moving forward, it can also cause narrowing around the nerves. So you go in, you take out the discs, you put in bone graft, you put a spacer, which is made of plastic, so it's got little metal markers. Those are those little dots in there. So we got the side view and the back view, and sometimes it works. And there's also, because of the stability of the screws just by themselves, patients often have what's called a honeymoon period. So it's great because they feel better when the screws are there, but if it doesn't work, they wind up getting getting pain later on, because the screws will start to get loose and the fusion sometimes doesn't fuse. Now, the way we stabilize that is very often, talking about lumbar, because neck is with a plate, is with pedicle screws. Pedicle is a part of the anatomy of a vertebral segment, a vertebral bone. So the vertebral body's in the front, the pedicle is like that tube of bone that connects the front to the back. And hopefully this diagram sort of shows you want to get a screw in this area. Well, there's not a lot of room for error. So if you get it too medial toward the midline, you'll get nerves. Too lateral away from midline, you won't be biting anything. So when you look in, this is a great diagram, and you would be looking for the landmarks of where to put the screws. But in reality, it looks like this. You don't get a lot of information a lot of times. So you have to be surgeons be very focused, you know, at least me in my mind's eye, like what am I looking for? Sometimes you have to use fluoro, you know, or x-ray to put a marker in or something like that. You don't want to get it wrong. You make a little drill on your starting point and then use a pedicle probe that's often referred to as a gear shift, because check it out, it looks like a gear shift. But you know, you're driving it in with a lot of parts of the feel of a surgeon, and you know, you can tweak it one way or another, but you know, it's very tactile, and if it gives way, you might not be in the right spot. So like here's some examples of a screw that's too medial, too much to the midline, and that is going to cause nerve damage. And one thing with the neuromonitoring, they stimulate the screw, and this one is going to have a very low threshold, because if the screw is in the bone, you got to get to certain volts before it actually contributes to stimulating the nerve. This one's going to be like nothing, like you can barely touch it, leg jumps. And that shows how the screw is too medial. Here's an example of a screw that's too lateral. It's not going to hold the bone. So I mean, if you're relying on it to hold things in place while the bone graft is healing, that's going to be not great. So just talk too fast anyway. But I'm going to go over another thing that you see commonly, which is neck. Okay, so I don't know if you've heard this surgery. It's pretty common. Probably 1 week. Stands for anterior front cervical neck discectomy. Take out the disc and fusion. So here's an example of a one-level case. You know, a lot of times the patient has both nerve impingement and some narrowing, and you take out the disc and you put in a spacer, and then a plate goes on the front. And it can also be done when there is instability. So here's a case where like someone else did laminectomy on the back, and then when they bend forward, there's abnormal motion there, and you have to stabilize it. I'm going to do a little self-promoting here, because I did a video, and it's on my website, which if you go to Dr. Walken, if you want to look at it, under the spine section, there's a drop-down menu, and then it says surgical treatments and ACDF, and on that page there's an 18-minute video. Now, that video is longer than most people would pay attention these days, but you know, I feel like I've gotten some, you know, decent reviews on it. But it started out with you know, a video of things through the scope, and then they got to be longer, because it would be like if you're looking through a straw at a room you've never seen before, and you have to explain what's going on in the room, what's up, what's down, and what's happening. If I could briefly summarize it, you go in through the front through an incision that is cosmetically not terrible, earrings not included. We go between the throat, the trachea and esophagus on one side, and the carotid on the other. So it's not that painful, because the only thing we really cut is the skin. Everything else we go between. So we get to the front of the spine. We have to put something metal in there, because the 3 most common reasons for litigation in spine surgery is wrong level, and wrong level. So you have to be always very careful that you're getting the right level. So once you get to the front and you verify, from the front you can decompress. You take out the disc and you decompress the nerves, but it creates a space. And if you didn't put something in there, it would collapse and bend forward. So you have to put a spacer in. The bone will grow through it above and below. You stabilize it with a plate on the front. And the patient wears a collar for about a month. And it's mainly to remind them not to do too much. And it's like a sign on their body saying, don't tackle me, I just had neck surgery. If you want to try to put on that collar, go to Walmart. It's like it's a force field. People stay another foot away from you. And usually they live happily ever after. So what are the conclusions? You know, again, like what's the big picture to share with you all? I was listening to an interview, and someone was asking a chess champion, what is the best move? And it's an impossible question, because you all have to react to what is happening at the time. And you can't answer that question any more than you can say what's going to happen way in the future, because it depends on what's going on. In fact, every patient is different. They're all our little snowflakes. And if you look at videos of how to do these procedures, they're doing it on someone like this with a great anatomy, but in fact, they wheel them in, and this is who I get. Or they might be a smoker, or they might be an osteoporotic person, and instead of putting screws into bone, I'm putting an induced styrofoam, and you don't get a good purchase. So we have to deal with what we get. You know, for the people who are students, I feel like, you know, you try to learn what you can, and you get thrown in the deep end. And unfortunately, that's sort of the way it is. If you think about anything you've learned, the first time you've done something is different than the 20th, it's different than the 100th. But I mean, at some point, you get more confident with, you know, doing what you're doing. For me, dreaming the impossible dream is to have the scrub people have the attitude they kind of know what's going on, and that they know how to do the case, almost to the point where if I died, they could finish it. Well, obviously not going to finish it, but it puts us on the same wavelength, because they're kind of with me, and potentially even ahead, knowing what's going on. But the reality is every doctor is different, and we're all going to say ours is the only way to do it, and yes, sir. You know, in fact, that was what someone said, what's the F word in Filipino? Yes, doctor. So we're like, you know, it's like herding cats with all different opinions. And when you're in the learning phase, you've got all these mentors around, people you can ask. But on the other hand, you're also under a microscope, so you're not really free to do what you want to do. But at some point, I mean, it's really a race to get as much knowledge as you can before the training wheels are taken off, because then you're on your own, right? So I think in terms of an attitude to approach your cases, there's these two ideas of like offense versus defense, right? To me, offense is like, what's going on? I'm going to research this. I'm going to know what's going on. Talk to a surgeon before, unless you can't find them or whatever, maybe for a few minutes just to go over it. Defense is, please don't yell at me. Okay, so you're always going to be wrong in defense. But if you're, when I was in medical school, I wanted to be a surgeon, and they came and said, "You're not making it." You know, like what? Crying. What can I do? And somewhere along, I don't know, someone told me or I got it, but you had to become, have the attitude that, wait, I'm the doctor. Instead of trying to read the resident's mind, do they want me to go to a lecture or do a talk about something? No, I'm the doctor. Then I'm going to be on the same wavelength. Like, hey, this person has a pneumonia. What is the chest X-ray show? Oh, I'm the doctor. I need to know that stuff. So if you're ahead of the ball, you know, like thinking like, what's going to go on? How do I be there? That's the winning strategy. The other thing is just, you know, keep it open mind. Things come up, things that, you know, you think would be obvious aren't. I mean, just even one word can have different interpretations. Like, this is a car, and this is a car. So unless you get more clarity, you know, you really aren't sometimes on the same wavelength. Anyway, I'm sure I've exhausted you all. Hopefully I've maybe brought a ray of sunshine, but that's my deal. I do have a website if you want to check it out. And